Have you ever had an anxious mom in your clinic worried her baby keeps bringing up milk? Is it just reflux or could it be something more serious? Hey GP trainees, my name is Dr. Erwin Kwun. I have doctors pass at SCA so they can finish training. Baby reflux is common, but knowing when to reassure and when to investigate can be the difference between a pass or a fail in your SCA. Imagine Mrs. Patel calls you about her 7-week-old son Arav. Doctor, my son is vomiting after every feed. It's been going on for 3 weeks. Further questions reveal vomiting is effortless, more like milk just spilling out, sometimes a bit curdle. It happens after most feeds, a little comes up even an hour later. There's no bile staining or blood, it seems otherwise well, alert, smiles, sleeps in 2 to 3 hour stretches. Arav is being exclusively breastfed, feeding every 2 to 3 hours. Mrs. Patel is worried she doesn't have enough milk because he wants to feed again quickly. When you ask about wet and dirty nappies, he's got 5 to 6 wet nappies a day. The stool is yellow, soft 2 to 3 times a day. When you explore the graph, the baby is tracking well along the 50th centile. You ask Mrs. Patel, what do you think is going on? I think it might be reflux, doctor. My sister's baby had it. When you're asking about the concern, you find out that the patient is scared that the baby choke in his sleep, and the mom is hoping that you could give him some Gaviscon. It's important to differentiate between gastroesophageal reflux versus gastroesophageal reflux disease. GO is common in infants. It is considered physiological when symptoms are absent or not troublesome. Key reassuring points are thriving baby, they're happy, they're gaining weight. GORD, on the other hand, is when it's more than just a spit up. GORD is when reflux causes troublesome symptoms or complications. Think about distress, poor feeding, respiratory symptoms. Some babies arch their back, faltering growth. So what do you look for in the history? When you're taking a history, it's really important that you check when did the symptoms start, the onset. Typically, it starts within a few weeks. If it's happening after 6-month onset, think twice. Could be something else going on. Also consider what's the pattern of the reflux. Is it after feed? Is it at night? Consider asking about the volume estimates. Explore the feeding history. So is a baby being breastfed or bottle fed? What's the volume, frequency, positioning? Any issues like gagging or choking? Be careful of overfeeding. So you ask about wet and dirty nappies to check the hydration and gut health. You also check about any family atopy history, any allergies, and the impact on the family. How is the mom coping? Is the mom able to get support? Examination is typically normal in most cases. You can check whether there's any signs of any dehydration, check for any weight loss or faltering growth. Look for respiratory signs, abdominal masses, or any bulging fontanelle. Red flags you can't miss in this presentation would be projectile vomiting. Think about pyloric stenosis. Bile stain vomit. This would suggest obstruction until proven otherwise. Abdominal distension, tenderness, masses. This would be something that you have to take seriously. Blood in vomit or stool, possible bleeding, cow's milk protein allergy or infection. Bulging fontanelle, this would indicate raised intracranial pressure. Persistent faltering growth, this needs to be escalated. Feeding aversion, unexplained anemia, dysphagia, typically this would need a pediatrician input. It's vital that you consider your list of differentials, so don't just narrow down to reflux, but think about cow's milk protein allergy, if there's any signs of eczema, rash, GI symptoms. Could it be colic if the child is crying later in the day, legs drawn up, otherwise healthy? Could it be due to lactose intolerance? It's less common in infants, but often post-gastroenteritis. So how do you manage reflux? So if it's gastroesophageal reflux and the baby is thriving, then you can reassure the parent that this is normal and usually resolve on its own. Reflux happens because the muscle at the bottom of your baby's food pipe is still weak. So milk can come back up. As your baby grows, its muscle gets stronger, the reflux should stop. Give some practical tips such as feeding the baby upright, keep upright for 15 to 20 minutes afterwards, burp them regularly, smaller, more frequent feeds, and advise a mom that there's no need for medication. It's not advisable to raise a cut head neither. For suspected GORD, but the baby is well, consider thickened feed or Gaviscon infant for 1 to 2 weeks. Explain the side effects of Gaviscon. Typically, it can cause constipation. If formula fed, reduce the volume and increase frequency. If the symptoms persist, then you would consider whether a trial of PPIs for 4 weeks would be indicated. If it's still not resolved, then this would be a red flag and you would need to consider referral. So how would you handle this scenario in the SCA? So if you want to reassure the mom, you could say to the mom, it is very common for babies to bring up milk. Their tummy valve is still developing. It usually gets better by 1 year. Practical tips: so burp your baby regularly during and after feeds. Try keeping him upright 15 to 20 minutes after feeding. Smaller, more frequent feeds can help. Address the fears of the mom. Sleeping on his back is safest, even with reflux. Babies' airways are designed to protect them. Give written safety netting if needed. Come back if vomiting becomes forceful, green, or he seems to be less responsive, dehydrated, or stop gaining weight. It's important that you involve the mom in the plan and make a shared management plan. So see whether the mom agrees with your plan, and you can check. We'll monitor his weight. If things worsen or doesn't settle over the next few months, we can consider other options like frequent feeds or medication. Right now, there's no need for medicine, which can have side effects. What do you think? Signpost the mom about the health visitor could help and give further advice if needed. Let's go over another case study. Your next patient is Mrs. Ali with a 6-week-old baby girl, Sophia. Mrs. Ali tells you, Doctor, Sophia keeps vomiting after feeds. It's so much. I'm scared that she's not keeping anything down. Further questions reveal vomiting is effortless, more like milk dribbling, or sometimes quite a bit come out, usually within 30 minutes of feeding. There's no bile or blood. Otherwise, Sophia seems to be happy, alert, smile, and is generally content. The feeding history revealed that the baby is bottle fed since birth. Mrs. Ali is giving 120 ml every 2 hours, and she tells you she cries a lot after feed, so I thought she was still hungry. Sometimes gives extra if Sophia cries. So 7 to 8 wet nappies per day, yellow soft stools 1 to twice a day. When you check the graph of the baby, the weight has jumped from the 25th to the 75th centile in the last 4 weeks. Eliciting the mom's health belief revealed that her idea is, I think it's reflux. My mom said she's bringing up too much milk. When you ask about the concern, you found out that, I'm scared she's not getting enough, doctor. An expectation, I was hoping for some medicine. So what do you think is going on here? Most likely, this baby is being overfed, leading to functional regurgitation, physiological gastroesophageal reflux. Sometimes babies do have silent reflux, in which case they might not be bringing up any milk. Baby stomachs are small, about the size of a large egg at this age. Feeding too much too often overwhelms the gastric capacity, increasing spitting up. There's no concerning red flags. The baby's happy, hydrated, thriving. In fact, possibly gaining weight too quickly. So how would you handle this in the SCA? So it's important to educate the mom with empathy. It's really common for babies to bring milk back up if their tummies are too full. I can see you're doing everything you can to keep her well fed. Explain the normal stomach size and cues. At 6 weeks, Sophia's tummy can only hold about 90 to 100 ml comfortably. Feeding more than that or too often makes it more likely she'll spit up. Sometimes babies also cry for comfort, not just hunger. A fair feeding plan. It's really important that you know the volume that is recommended based on the weight of the baby. For example, an infant, typically you would recommend 150 ml per kilogram in 24 hours. So based on the patient's weight, then you can recommend, for example, you could reduce the feed to 60 ml every 3 hours and watch for hunger cues before offering more. Encourage weaning during and after feeds. Keep upright for 15 to 20 minutes after feeding. As long as Sophia is happy, hydrated, and growing well, we don't need to use medication, which can have side effects. Adjusting the feeding often does a trick. Make sure you don't forget safety netting. If she starts to vomit forcefully, if the vomit is green or bloody, if she seems more sleepy than usual or stops having wet nappies, I'd like you to come back immediately, and if you're ever worried, please call 111. If you want to get clear paths, it's important that you adapt your explanation. So you could use metaphor, for example. Think of her tummy like a small balloon. If we keep overfilling it, it'll push milk back up. Reframe parental concerns gently. I can see why you are giving extra feed when she cried. Many parents do that. However, they're seeking comfort or needing weaning. So document the feeding volumes, frequency clearly. That will help the mom to know how much to feed and how frequent. So here's a classic SCA case where overfeeding is a primary cause of regurgitation. The key is to educate the parents sensitively, adjust feeding, give clear safety net advice, and avoid unnecessary over-medicalization. That's how you demonstrate being safe and effective as an independent GP. If you want more case examples of SCA consultation, then you might want to watch the next video on ADHD. Click here to watch it, and I'll see you on the other side.